In this lecture, we will cover hematologic disorders and oncologic emergencies. To start, I'd like to talk about the coagulation cascade. So hemostasis is the ability of the body to control bleeding and clotting. And there are four major actions that are involved in achieving homeostasis. So let's talk about those four actions. First off, you'll start with local vasoconstriction to reduce blood flow. Then you'll see platelet aggregation and formation of a platelet plug, followed by formation of a fibrin mesh to strengthen the plug, and then clot dissolution after the tissue repair is complete. So those are the four overarching features of hemostasis. The coagulation mechanism consists of 13 factors that work together to achieve hemostasis. And there are two components, overarching components to this process, and that would be the intrinsic pathway located on the left and the extrinsic pathway. So the intrinsic pathway is activated when there is damage to the subendothelium of vessels, and the subendothelium comes into contact with circulating blood. In this contact phase, proteins activate additional coagulation factors, and the two pathways converge into a common pathway. The common pathway and prothrombin and fibrinogen are converted to their active forms, resulting in clot formation. Now, platelets are activated by the arrival of thrombin at the site of injury, and local platelets change shape. They become sticky and begin to aggregate along the vessel wall. Activated platelets undergo degranulation and a releasing of several factors to assist in clot formation. Also, serotonin and histamine help to limit blood loss while the clot is forming. As well, there are prostaglandins, one in particular known as TXA2, that contribute to vasoconstriction and promote further platelet degranulation. ADP, or adenosine triphosphate, recruits platelets by increasing adherence and degranulation, and then the process continues. Factor 10 is converted into its active form, enabling the conversion of prothrombin to thrombin, then converts from fibrinogen to fibrin. Strands of fibrin form around the clot, creating a net that traps platelets, red blood cells, and white blood cells. And that clot is further secured to the site as a platelet actomyosin causes it to contract and consolidate. So that's an overarching picture of the coagulation cascade. Under normal conditions, there's a feedback system that prevents coagulation from spinning out of control, and prostacyclin is released from damaged endothelial cells. This counteracts the effects of TXA2 and also serotonin and histamine through vasodilation and inhibition of platelet degranulation. So again, prostacyclin is that one of those kind of feedback mechanisms that prevents overclotting. Another means of regulating clot formation is through inhibition of the enzymes necessary for the activation of the coagulation factors, and this prevents the conversion of prothrombin to thrombin. The most important of these regulators is antithrombin 3. However, protein C and protein S also play a role in thrombin inhibition. Now, the process of fibrinolysis promotes dissolution of the remodeling and the remodeling of the clot to promote repair of the vessel wall and to maintain flow through the vessel lumen. And fibrinolysis begins as soon as fibrin is the clot is formed. And so circulating plasminogen, which is a precursor to the powerful enzyme plasmin, binds to fibrin and is trapped within the newly formed clot. The injured epithelial wall releases TPA, or tissue plasminogen activator, which converts plasminogen to its active state, which is plasmin. And then plasmin begins to digest the fibrin, and the clot then will rapidly break down the clot. When fibrin is broken down, the fibrin degradation products that are released as an act and they act as anticoagulants. Okay, so quick question. What is the ability of the body to control bleeding and clotting called? And the correct answer would be C, hemostasis. Okay, now let's talk about the first disease process that we're going to go into, and this would be disseminated intravascular coagulation, or DIC. DIC is an uncommon syndrome that arises as a complication of other serious life-threatening conditions. Another name for this is actually consumptive coagulopathy, and it's characterized by bleeding and thrombosis, both of which result in the depletion of clotting factors, platelets, and red blood cells. Now, if untreated, DIC will quickly progress to multiple organ failure, and the exact underlying trigger of DIC it may not be identifiable. However, sepsis in particular is a primary cause, and oftentimes gram-negative organisms can be identified roughly in about 20% of cases, and so we should be watching out for DIC in our septic patients that we get. Now, regardless of the cause, what happens is there's damage to the endothelium that results in an activation of the coagulation cascade. And the direct damage to the endothelium results in the release of tissue factor and then activation of the extrinsic pathway. The excess of thrombin formation results in rapid consumption of the coagulation factors and depletion of regulatory substances. Left unchecked, thrombi will continue to form along damaged epithelial walls, and this will result in an occlusion of the vessels. As occlusion reaches a critical level, tissue ischemia can occur, and this will eventually lead to tissue damage and kind of a self-perpetuating process. Eventually, end organ function will be affected, and ultimately the organs could fail. In response to the clot formation, however, the fibrinolytic system is activated as plasmin breaks down the fibrin clots. There are fibrin split products that are released, and they act as anticoagulants. Now, coupled with the depletion of circulating clotting factors, we can anticipate that the patient will bleed, and the end result will be shock from and then that will lead to further tissue ischemia. Ultimately, if the process is not stopped, death will be imminent. And so DIC, we are trying to identify the cause and then reverse the cause of the disseminated intravascular coagulation. Regardless of the cause, this diagram basically lays out what happens in DIC. And we can see at the top whether it's massive tissue destruction, sepsis, or endothelial injury. Ultimately, this leads to a release of tissue factor. And with endothelial injury, we then see platelet aggregation. Ultimately, there is widespread microvascular thrombus, which will lead to the consumption of clotting factors and also fibrinolysis. And then with the microvascular thrombus, we see tissue ischemia because of clots that form and go distal. And then ultimately, because of the fibrinolysis and the consumption of clotting factors, we will see bleeding. So it's a disease of bleeding and clotting and bleeding and clotting. Ultimately, for a favorable outcome with DIC, we need to identify that the patient is actually in DIC, and one of the primary ways that we do that is through the laboratory values. Now, the laboratory tests used to diagnose DIC essentially assess the four basic characteristics of DIC, and that would be increased coagulant activity, increased fibrinolytic activity, and impaired regulatory function, and finally, end organ failure. The primary intervention in DIC is prevention. After DIC is identified, maintaining organ perfusion and slowing the consumption of coagulation factors are paramount to achieve an optimal outcome for the patient. Multiple organ dysfunction syndrome, or MODS, frequently does result because of DIC, and it's absolutely essential to stop this process to be able to prevent the patient from going into multiple organ dysfunction. Fibrinogen levels less than 100 milligrams per deciliter indicate the appropriateness of administration of cryoprecipitate. So that is one of the things that we do to medically manage these patients. So if the fibrinogen level is less than 100 milligrams per deciliter, then we will administer cryoprecipitate. The slowing of consumption or coagulation factors by inhibiting the process involved in clot formation is another strategy that we use for DIC, and the use of antithrombin 3 has recently been approved in the United States, and the introduction of protease inhibitors by intravenous infusion may also help the patient who is suffering from DIC. So some of the nursing management that we deal with is supporting patients' vital functions, initiating bleeding precautions, and then providing comfort and emotional support. The next topic we're going to discuss is thrombocytopenia. So thrombocytopenia is defined as a platelet count less than 140,000 millimeters cubed. And the onset of thrombocytopenia often follows a few different common themes, and I'll give you some of those. So viral infections, pregnancy, administration of certain medications like heparin, thiazide diuretics, chemotherapeutic agents, also malignancies, splenomegaly, blood transfusions, and alcoholism are sometimes culprits for thrombocytopenia. Now, regardless of the precipitating condition, the development of thrombocytopenia occurs by means of one of four mechanisms. And so here are the four mechanisms. Either a decreased platelet production, increased platelet destruction, splenic sequestration of platelets, and platelet dilution. The most common form that is seen in critically ill patients is immune thrombocytopenic purpura, and that's also called ITP. In ITP, lymphocytes produce antibodies that begin to destroy existing platelets. The cause is actually not known, and with insufficient platelets available, the normal coagulation pathways are disrupted, and therefore inadequate hemostasis will ensue, and ultimately bleeding will result. Gastrointestinal and intracerebral bleeding can occur. The bleeding seen in ITP does not usually result in deep visceral hemorrhage and hematoma. ITP is usually characterized by the gradual onset of symptoms, and the diagnosis is primarily based on the findings in the patient's history in the physical examination. The common findings are petechial hemorrhages, which can manifest as small red spots primarily on the legs and oral mucosa, and they are indicative of a platelet disorder, and unusual bleeding is also a hallmark of ITP. A complete blood count would show a severely diminished platelet count, which is often less than 30,000 for a patient with ITP. Interestingly, the number of red blood cells and white blood cells, as well as the hemoglobin level and the coagulation studies, and as well as the bleeding times, are often normal in patients with ITP. In most cases, it will resolve spontaneously and medical treatment is not necessary. In mild cases, the patient may be administered oral corticosteroids, and in patients with life-threatening hemorrhage, rapid intervention is necessary. One of the medical treatments is intravenous immune globulin and high-dose methylprednisone. This is an effective treatment for ITP. If steroid therapy does fail, then surgical removal of the spleen can be considered. Now, the nursing management of the patient with ITP incorporates a variety of nursing diagnosis. The nursing interventions include supporting the patient's vital functions, initiating bleeding precautions, providing comfort and emotional support, and also maintaining surveillance for complications. Moving on to another form of thrombocytopenia, we have the heparin-induced thrombocytopenia, also referred to as HIT. The most common form of HIT is the non-immune mediated type, which is type 1. The second form is called type 2 HIT, or immune mediated HIT. Type 1 is non-immune mediated and type 2 is immune mediated. Type 2 HIT is more severe, and that's the immune mediated type. Immune mediated HIT is a response to the administration of heparin therapy. The disorder is characterized by a severe thrombocytopenia during heparin therapy. Now, diagnostically, it is identified by a platelet count less than 50,000 or at least a 50% decrease from the baseline platelet count from the initiation of therapy. So again, the way this is diagnosed is if the platelet count is less than 50,000 or you've seen a 50% decrease from baseline of the platelet count. And the first onset occurs between 5 to 14 days. Onset from re-exposure may occur within hours. The thrombocytopenia that occurs is related to the formation of heparin antibody complexes. Now, these complexes release a substance known as platelet factor 4, or PF4. PF4 attracts heparin molecules, forming immunogenic complexes that adhere to platelet and endothelial surfaces. And what happens then is you have activation of platelets, and this stimulates the release of thrombin and the subsequent formation of platelet clumps. Patients with immune-mediated HIT or type 2 HIT are at a greater risk for thrombus than for bleeding. The resultant formation of fibrin platelet-rich thrombi is the primary characteristic of HIT that distinguishes it from other forms of thrombocytopenia, and this gives rise to its more descriptive name, white clot syndrome. So the rapid recognition of risk factors and the subsequent development of signs and symptoms is essential for treating this condition. The clinical manifestation of HIT is related to the formation of thrombi and subsequent vessel occlusion. And as mentioned, clotting is the hallmark sign of HIT, and so we're going to be looking for signs of tissue ischemia, both in the organs and also on the skin. We can see areas where skin perfusion is decreased. The key indicator for identifying HIT is the platelet count, and general consensus in the literature considers a platelet count less than 100,000 millimeters cubed or a sudden drop less than 50% from the baseline for initiation of heparin therapy to stop. And this, if you see this when heparin therapy is going on, it is a strong indication that the patient is developing type 2 HIT or heparin-induced thrombocytopenia. Current guidelines recommend that platelet counts be monitored at least every 2 to 3 days from day 4 to 14. And then when a decrease in the platelet count is detected, heparin therapy should be discontinued and the patient should be tested for heparin antibodies. Direct thrombin inhibitors can be used to treat HIT, and these are also referred to as DTIs. DTIs basically bind directly to the thrombin molecule, thereby inhibiting the action of thrombin. 2 such medications are currently used in the United States, and the most common one is argatroban. The nursing management of the patient with HIT incorporates a variety of nursing diagnosis, and the nursing interventions include decreasing the incidence of heparin exposure, maintaining surveillance for complications, providing comfort and emotional support, and then also educating the patient and family about the disease process and about the potential outcomes, and just preparing them. Ensuring that all heparin has been removed from the patient's hemodynamic pressure monitoring systems, and then avoiding any kind of heparin-coated catheters or any kind of heparin flushes has to be paramount in part of the care. Patients with HIT do remain at high risk for thrombotic complications for several days to weeks after the cessation of heparin. So you really have to monitor them closely for early recognition of signs and symptoms of deep vein thrombosis. Prompt notification to the physician, of course, is indicated if you recognize any signs and symptoms of thrombus formation. And prevention of subsequent episodes in a patient sensitized to heparin includes educating the patient and family about how to avoid exposure to heparin in the future. The use of a medical alert bracelet is indicated for someone who has a heparin allergy, and anybody who has developed HIT is considered to have a heparin allergy. Moving on to the next topic, we're going to cover sickle cell anemia. Sickle cell anemia is a disease that's passed down through families in which the red blood cell doesn't form properly, and it becomes an abnormal shape, and it looks like a sickle. The sickle cell shaped red blood cell has a shortened lifespan, and it's unable to effectively carry oxygen to the tissues, and it becomes trapped in the vasculature. This trapping of the red blood cell in the vasculature causes pain, and it increases the risk of infection and other serious complications. And sickle cell anemia is an autosomal recessive genetic disorder. This genetic trait is primarily found in people from West African descent and may rarely be found in persons of sole European or Middle Eastern ancestry. Now, sickle cell anemia is usually diagnosed during the first few weeks and years of life, and prenatal screening is available. The hemoglobin becomes rigid and very friable, causing vaso-occlusion in the small vessels of the circulatory system. So ultimately, this leads to red blood cell becoming lodged in the vasculature and the microcirculation causing stasis and obstruction of blood flow, and then damage to the surrounding organs and tissue ischemia and infarction will occur. So the patient may present with low-grade fever, bone or joint pain, pinpoint pupils, inability to follow commands, photophobia, tachycardia, tachypnea, decreased respiratory excursion, hepatomegaly, non-palpable spleen, and peritibial ulcers. The initial laboratory studies should include a complete blood count, a peripheral blood smear, and a quantitative hemoglobin electrophoresis. Sickle cells will constitute roughly 5 to 10% of the blood smear, and the elevated reticulocyte count greater than 10% is characteristically accompanied by the presence of what is called Howell-Jeweley bodies. Typically, an elevated white blood cell count occurs during the following of a crisis. Other tests might include an indirect bilirubin level, which will be elevated following hemolysis. The hepatoglobin level will be low or absent because it cannot be replaced quickly enough after severe hemolysis. So the medical management of sickle cell anemia includes bone marrow transplant, and this offers a cure in a limited number of cases. Medical interventions are aimed at preventing infections, managing pain, transfusing red blood cells when needed, and then administering hydroxyurea. Patients with chronic disease are more effectively managed through a multidisciplinary approach. It's also important to look at other issues that may exacerbate the patient's disease, and such things include the diet, poor housing, a lack of education about their disease, and then poor access to services, as well as poor lifestyle choices. The pain associated with sickle cell anemia can vary enormously. Therefore, a number of different approaches need to be taken when it comes to the medication management. The medication of choice should be influenced by the patient's history of analgesia use. Non-pharmacologic approaches can include psychological support, massage, transcutaneous electrical nerve stimulation, and transfusion therapy is primarily used for the treatment when patients are experiencing complications due to a sickle cell emergency. The indications for having a blood transfusion or an exchange are recurrent painful vaso-occlusive crises with long hospital admissions, acute chest pain syndrome, stroke, priapism, and leg ulcers. Now, hydroxyurea works by increasing the level of fetal hemoglobin in the red blood cells. Therefore, what it does is it reduces the concentration of sickle hemoglobin and sickling itself. Patients receiving hydroxyurea have lower episodes of pain and acute chest pain syndrome, and they have a decreased need for blood transfusions as well. So hydroxyurea is one of the very important key medications that is used for sickle cell anemia. Nursing management of the patient with sickle cell anemia incorporates a variety of nursing diagnosis, and if you actually look at box 3810 in your book, you will see the common nursing diagnoses. And of course, they're very similar to the other nursing diagnosis of patients with anemia, including vital functions, comfort, emotional support, and then surveillance, maintenance and surveillance for complications. And finally, educating the patient and the family about the disease process. Signs of life-threatening complications include septicemia, acute myocardial infarction, priapism, ischemic stroke, and shock. The patient and the family should be taught about sickle cell anemia, its causes, and its treatment. Education should focus on the measures to help prevent pain and the reoccurrence of episodes. The next topic we're going to discuss is tumor lysis syndrome. Tumor lysis syndrome refers to a variety of metabolic disturbances that may be seen with the treatment of cancer. This is a potentially life-threatening complication, and it occurs when large numbers of neoplastic cells are rapidly destroyed by the chemotherapy or whatever treatment the patient is undergoing that results in the release of large amounts of potassium, phosphate, and uric acid into the bloodstream. It's most commonly seen in patients with lymphoma, leukemia, and multiple metastatic conditions. Although most often it's associated with chemotherapy, medications, biological agents, and also irradiation may induce TLS, or tumor lysis syndrome. It very rarely occurs spontaneously in the cancer patient. Development has been linked to other pathophysiologic conditions such as elevated white blood cell count, large tumors, and also multiple organ involvement by malignancy. The primary mechanism involved in the development of tumor lysis syndrome is the destruction of those malignant cells. And as mentioned before, massive destruction of these tumor cells releases large amounts of potassium, phosphorus, and nucleic acids, which leads to a severe metabolic disturbance. Hyperuricemia usually occurs within 48 to 72 hours after the initiation of the cancer therapy. Hyperkalemia usually occurs within the first 6 to 72 hours after the initiation of chemotherapy. So monitoring of the potassium level within that time frame is very important. The resultant hyperkalemia may lead to a profound effect on the cardiovascular system and can result in cardiac arrest and death. Hyperphosphatemia and hypocalcemia usually occurs between 24 and 48 hours after the initiation of therapy, and hypocalcemia causes tetany and cardiac dysrhythmias, which can also result in cardiac arrest and death. This diagram demonstrates what I just taught you, and we have the malignant cell lysis, which results in the release of uric acid, potassium, and phosphorus, which ultimately leads to cardiac arrhythmia, cardiac arrest, and respiratory failure. So the key is detection and recognition of tumor lysis syndrome. And we're going to do that through looking at clinical manifestations, laboratory findings, and also a couple of other diagnostic tests. The weight gain that is associated with fluid retention due to the electrolyte disturbances is one of the hallmark signs. And then other early signs include diarrhea, lethargy, muscle cramps, nausea and vomiting, paresthesias, and weakness. Laboratory findings demonstrate electrolyte disturbances such as elevated potassium and phosphorus levels, and then decreased calcium levels. Uric acid levels are also increased. So elevated levels of BUN and creatinine and also decreased creatinine clearance can occur, and this indicates that the patient's kidneys are affected by the tumor lysis syndrome. Ultimately, this can lead to metabolic acidosis, and this is confirmed by obtaining an arterial blood gas. Physical exam can reveal a positive Chopsteck's and Trousseau sign that's related to the hypocalcemia. Also, the patient may have hyperactive deep tendon reflexes, which would indicate hyperkalemia and hypocalcemia. And potassium and calcium disturbances result in changes that can be seen on the ECG, such as peak T waves, and then also altered QT intervals, widened QRS once the potassium gets very high, and finally rhythm disturbances like ventricular fibrillation. The overall medical management focuses on 3 areas: adequate hydration, metabolic imbalance correction, and then treating life-threatening complications. Administration of intravenous fluids may be necessary early in the course, and the administration of normal saline reduces the concentration of all of the electrolyte disturbances and the high levels of uric acid. Electrolytes and arterial blood gases are closely monitored during this time, and dietary restrictions of potassium and phosphorus are necessary to help reduce those levels. The goals of treating hyperuricemia are to inhibit the uric acid formation and to increase renal clearance. This is best accomplished through the administration of sodium bicarbonate, and this will also have another effect of increasing the pH of the urine to above 7. And what this does is it will increase the solubility of uric acid in the urine. It as well will help to prevent crystallization. Allopurinol administration can also inhibit uric acid formation, so you may see that that is sometimes given. If potassium levels rise to dangerous level, then administration of insulin and glucose may be necessary. As well, you may need to administer Kexalate. A 10% solution of calcium gluconate also may be administered to treat life-threatening dysrhythmias and the low calcium level. Phosphorus binding antacids may be used to treat the hyperphosphatemia, and then calcium gluconate may be required to replace the calcium. This concludes our lecture on hematologic disorders and oncologic emergencies. Thank you.